So it's now time to turn to our panel discussion. So, Richard, thank you very much for taking your seat. And if I could ask the other panellists to join you now, please welcome them. They are Joan Russell, who is the Associate Director of Patient Safety at NHS Improvement and the lead sponsor of the Think Kidneys programme. Fiona Loud, who is the Policy Director at the British Kidney Patient Association, who has been on the programme board and co-chaired the RISK workstream. Dr. Mike Jones, who you saw in that film, who was an acute physician working at the University Hospital of North Durham. Mike is chair of the AKI National Programmes Education Workstream. And Dr. Tom Blakeman, a GP and senior lecturer in primary care, as well as the lead for kidney health programme clerk in Greater Manchester for the AKI programme. Tom is co-chair of the intervention workstream and his interest lies in implementation of kidney health initiatives in primary care. Okay, so hopefully you're all welcome them. Yes, thank you very much. So, Richard, if I could start with you. We've heard some great things about the project so far, but what do you think the most important outcome of the project is so far?
Well, I mean, I think there were quite a few significant changes that we could talk about. And I think that, you know, we put in place changes in terms of individuals and the system. I think the most important thing for me is something alluded to in the film is that everyone talks about acute kidney injury. It is now part of the normal conversation that people have. And that, you know, is right from the work the labs did in terms of, you know, building the algorithm and how they perform, right through the whole spectrum of education and across that broad reach of people. And I think that is probably the biggest significant outcome that you can't measure, but you just know in terms of how you hear it when you go out and talk to people.
Thank you. We all know that it's been a complex project, especially bearing in mind the huge range and variety of stakeholders. So, Joan, can you tell, if I can turn you to first and ask, what have been the main learning experiences?
Sure. I mean, I think for me there's probably two really key areas of learning that I'd like to reflect on. I think the first one was, as Richard said, one of the key objectives that we had when we started the programme was that we knew that we wanted to be able to influence and positively improve the systems that's across NHS organisations, across sectors as well, which actually impact on the delivery of care for patients who have got AKI or at risk of AKI. And a number of ways that we did this were through the National Sequin, which was looking at improving the quality of discharge information, and we had 2 patient safety alerts. The first one was around standardising the detection of AKI through the use of the NHS England AKI algorithm, and the second one about promoting the resources. But I think from that, actually, when we're actually working, improving care in the system, it takes a while to actually see the impact of that and the improving the outcomes on the patients. So in reflection that the actual, going back to that first patient safety alert, whilst it absolutely really positively allowed us to look at how we improve the standardisation and the early detection of AKI, it's the fact that we were able, through the algorithm, to be able to start to create this national master patient index, which now really allows us to be able to measure in the long term the benefits of the system-wide initiatives as well as the local initiatives that have been in place. And that's at a national level and a local level as well. And then perhaps just the second thing that I'd like to reflect on, again, it was the complexity of the programme. I think when we started the programme, most of the work to date that had been done around improving the management of AKI had been in secondary care, but it was a recognition that we really needed to be able to reach across all sectors in the NHS and in social care as well. That was, you know, quite a significant learning for us. And, I mean, the work that we've done, I mean, Richard's already alluded to it to some extent in primary care, and just the work in care homes as well. I mean, that care home programme, which you'll hear more about later, is just a really fantastic example of how talking about AKI within a different sector, the outcomes that have come from that, the improvement, you know, the recognition of the importance of hydration has been fantastic.
Yeah. Thank you, Joan. And so then, Tom, just picking up from what Joan was saying, what do you think are the learning experiences in primary care?
I mean, I think what the programme has created is structures and spaces for shared learning collaboration, and I think that's been key and needs to continue. I think another key aspect with that is to ensure that sort of there's been learning based on a grounding of an understanding of everyday clinical practice. And reiterate a point sort of raised in the film. I think in terms of creating guidance for primary care, we had to the challenge and our responsibility to navigate the challenge of how do we ensure we maximise the clinical utility of, say, an AKI warning stage test result, whilst also sort of minimise the potential for burden on clinicians, GPs, in terms of clinical workload, and also for treatment burden for patients. And I think we needed to take steps. I think Charlie Thompson leading the group overall, that was a key aspect that we had to navigate through. And the steps that I think we've taken is that the work stream is multidisciplinary, and so that brought lots of different perspectives. We set up used RAND consensus methods, and I think that they were key in that they brought in different perspectives, and they ensured that the development of guidance was ensured that we put the test result and placed it in a clinical context all the time. And in doing so, you put it into context of people's everyday lives and working environments. I think within that RAND consensus, we invited GPs who probably represent the RCGP working group on overdiagnosis and concerns about medicalisation and get their input into it. So there's a balancing that's going on. I think from that, we went on to sort of get feedback nationally, and we sent out sort of draft guidance, and it was an iterative process, and we got constructive feedback, had to take that on board. And I think then that then led to going to working groups around the country, going to meetings with joint meetings up in the northeast in Middlesbrough with John Murray and GP colleagues, going to Bristol, chatting with out-of-hours doctors and also acute physicians, and a joint meeting there, and then also a sort of a meeting in London with people from the programme itself across the work stream. So I think that's key. I think navigating that challenge between maximising utility of being aware of AKI risk and minimising potential for burden for everyone concerned is a key aspect going forward as well.
Okay, thank you, Tom. It sounds like the hugely collaborative nature of it has been the huge success of it.
I think it's critical, and it's given the buzz and the passion that I think probably people feel in the room today that being part of it. So.
Thank you, Tom. So, Fiona, I know that the programme has been, and it's also mentioned in the film, has been very keen from the get-go to involve patients in its design and implementation. How important has this been, and what are your reflections on their involvement?
Yeah, thanks. I think that from the patient point of view, it's been absolutely vital to have not just a sort of tokenistic involvement, but actually have patients as part of every single work stream, really, really informing and driving the programme. It's almost like a stick of rock, I suppose, right way through the thing. When I first started talking about acute kidney injury, I realised that patients and the public, you've heard it already, had absolutely no idea what acute kidney injury might mean. But actually, patients who may be at risk in particular, it could be anybody who could get it, of course, but patients who are particularly at risk had no idea themselves. And so it was that dawning realisation that those of us who are at greatest risk didn't know what to look out for, didn't know what things we could do to perhaps avoid the really big harms of acute kidney injury was incredibly important. So I felt that having the views, when I've seen that, having the views of those and the experience of those people who've experienced kidney disease but also acute kidney injury in the programme was absolutely essential. And I think we should just take a moment to note that having some of those folk involved has been not just fundamental to the programme itself, but actually they've been through some really, really difficult experiences. Richard talked earlier about that feeling of drowning. That is what it feels like to have kidney failure. But imagine if that's you and you had no idea you were going to get it, and 24 hours later, that's how you were feeling. So people I've spoken to who've had AKI just talk about this really, really big shock they have, the sort of shock and the anger and the denial. But then some of them don't know what's going to happen to them later on, and perhaps they don't know how to, or they didn't know how to avoid getting acute kidney injury later as well. So I was very keen that we would produce, so with the British Kidney Patient Association, Think Kidneys and the Royal College of GPs, that we could produce some really good information for patients, but with patients. So some of our patient groups were part of producing that stuff to stop people, or to help people to learn what they could do to avoid getting acute kidney injury in the future, to avoid it if they re-getting it, had it before, but also some new stuff that's just come out today for families with children who might be at risk and for young people too. So all of that was kind of part of the work that we produced. But really key to all of this is that, you know, we are the stakeholders, and the stake in this is our life, because this thing happens every single day. I frequently meet people who've had acute kidney injury, but gradually I'm noticing people who will say, I had acute kidney injury, and I never used to hear that in the past. So I think that's a small step, but it's just so important that we keep on sustaining that, because new patients every day, new people every day are acquiring acute kidney injury, and it doesn't need to happen in every case. So the collaboration and the excellent outputs that we've produced as patients and professionals together has been fundamental to getting this programme going, but it's just the beginning. It doesn't finish here at all.
Thank you very much, Fiona. So, Mike, with Fiona's comments in mind, how do you see the contribution of patients to the programme from an education perspective?
Oh, I think it's been critical. I think we need to remember that every single person in this room could be a patient. I have to put my hand up as if I'm an Alcoholics Anonymous and say, I'm Mike and I've had AKI. But it's really possible for anybody to get this illness. And in truth, being in a hospital and being woken up at 6 o'clock in the morning to have your blood pressure taken, people need to be aware that your loss of freedom, etc., is actually quite a part of a depersonalization when you become unwell. And that itself is really important. But I would commend Michael Wise's book. It's not an advert, I'm not being paid for it, but Michael Wise's book, he was on our educational work stream. He had AKI and subsequently developed CKD and went on to get a renal transplant. His experiences, and I think the experiences of other patients, and Fiona's experience as well, are incredibly salutary and really quite humbling in terms of how we properly manage patients. And without that insight, it can be really, really difficult. So I think the roles of the patients within all of the program, all of the work streams, especially in the education work stream, has really helped us hone the work that we've been doing.
Mm-hmm. Thank you very much. That's very interesting. And do you think that's from your perspective as well, Joni? Is that true for you?
Yeah, no, I completely agree. I think the patient-public participation has been key. I'm just looking at Catherine, actually, on the desk here. I just think I'd like to reflect, for me, one of the really sort of salient points was when we were actually looking at the Moripol survey results at one of the programme board meetings, and Catherine was there. Catherine was a GP member of our programme board. And when they actually came out, I remember Catherine actually saying that after hearing those results, just how it would actually going to change, and how she really had to think now about the conversations that she had with patients that she was seeing who were coming to her with renal symptoms as a result of that information. And I think that's just an example of how having that information can really change, care for patients.
Right. Thank you very much. Mike, if I could come back to you again. With the development of the Master Patient Index, which we've now have 75% of labs contributing data monthlies, what difference do you think these data are going to have on patient care in the future?
I think this is a critical development. It was alluded to earlier on, for those of us that trained many years ago, that AKI, or acute renal failure as it was known, was, okay, you got it, you got better, and it was not really important. Even now, whilst this is a renal community dominated, the fact is that most patients with AKI are seen without the significant level of AKI that needs a nephrologist. But what we are able now to look at is right across the stages of AKI and see what outcomes are occurring, see how we can modify approaches, identify those at risk, try and get more information about patients, about how they're managed, and really try to use the incredible resource that's available to improve the overall management of patients, whatever stage of AKI they present with. I think it's really been very clear that over the period of time that the program's been running, AKI has become a thing that people are far more aware of. I had a colleague speaking to me the other day and saying, isn't it strange how we always used to talk about acute renal failure and now virtually nobody does. So there is a very significant trend of greater recognition. Now we need to use the resource and improve management and learn more about what's happening to patients.
Thank you very much, Mike. Richard, turning to the potential, which you mentioned in the film actually, of the wider influence of the programme, do you think that the AKI programme's work has had an impact on other work in kidney health?
I think, again, that's one of the unanticipated consequences of the work that's been done through Think Kidneys. I mean, the brand is quite powerful in itself, and that brand is a way in which we can hang a multiple set of agenda items onto it. And I think that, if we look back and reflect on what work has been done before, the perception for people of kidney disease was the transplant patients sat on the couch in breakfast telly talking about, how their life had been saved from that point of view. And that's very important. But the problem is it was about someone else. Whereas I think actually that what the acute kidney injury programme has allowed us to do is to make it relevant to everyone. And that's really powerful because everyone therefore has a vested interest. And that's both professionally. I mean, most nephrologists are Class A personalities and they sit in their ivory towers and they like to blame and fingerprint people as suspects, in kidney disease. But, we've made this relevant to a wider range of professionals and groups. And then I think, from a small, important group of patients, we've broadened it out to a much wider proportion of the public. And then the awareness that actually explaining about kidney health, how does that underpin the agenda around cardiovascular disease, premature cardiovascular disease, which is something we've struggled with for 10 years. There's a huge amount of scepticism around chronic kidney disease's role in that. I think this has reopened that debate and allows us to give a better exposition of the position. So I think that has been, a legacy that we could not possibly have guessed would have happened, but I think it's hugely, hugely powerful.
Well, that's very encouraging. Thank you very much. So some people like us, Joan, are going to be doing projects like this in the future. What are the things, do you think, that made the project work well from the beginning?
Okay, so I think, again, a couple of things for me here. I think in the first instance, I think the thing that made the project work really well was the way that the project, first of all, came together. And I think Richard was alluding to it in the first presentation that he did. So it was the fact that when Richard was, as NCD, obviously, for renal services in NHS England, was asked to lead this programme of work, the fact that Richard recognised in very early stages that this was really, around patient safety and around improving patient safety. So it was the opportunity that Richard then took to talk to Mike Durkin and myself and, to say, could we support this programme from a patient safety perspective, which we were able to do. So I think that was a real sort of good starting block. And the fact then we could actually set up a sponsor team, which was Ron Cullen, obviously Director for the Renal Registry, Richard and myself. And I think the fact that as a sponsor team we came together and we all really had that common vision that this was going to be a programme which was about, very much around safety improvement. Mm-hmm. So I think that was fundamental, that we all had that really common vision. And I think from that common vision we were able then to come and look at and set right from the start very clear terms of reference, which was around the scope of the project, what the key objectives of that project were. And having done those terms of reference, it was about getting the right people on the programme board who all supported and bought into those very clear terms of reference. I think that was a really important parts of the programme. And then having that clarity also allowed, because we had the number of interventions that were going on, the number of work streams, having that clarity through the terms of reference gave the vision, but also the flexibility that Richard alluded to be able to allow the work streams to, work independently to some extent, but again, to that common vision. And I think that's the final thing that I think to say, on the project that has been of this size, which was over 3 years, I think it was that early recognition that project management was going to be so key to this. And so the fact that we were able to bring in, a really strong project management team, led by Karen and her team, I think that was also really important to be able to have that for the success of a project like this as well, which was going across, the whole breadth of the system in looking at improving safety.
Thank you very much. And so very strong foundations from which to start. If I can turn to you kind of individually now and just ask in a short 30-second soundbite, if you'd had the chance to do something differently, what that might have been. So, Joan, if we could just start again with you.
Okay. So I think when you're looking at what we'd do differently, I think I'd want to go back to the first patient safety alert that we put out, which was around obviously the implementation of the AKI algorithm. When we issue patient safety alerts from NHS Improvement now, we always look at setting timescales for an implementation time on those timescales. And I think as we went through, we recognised that the timescale that we had put into that first patient safety alert for some NHS organisations to be able to implement the algorithm successfully into their LIMS systems was challenging. So I think with hindsight on reflection, what I would have done before we actually agreed the timescales for implementation of the alert would be to spend more time talking to the actual LIMS providers to understand the challenges that they were going to be facing in achieving the requirements of the patient safety alert.
Thank you very much. Turning to Mike, what are your thoughts?
I think from the education workstream point of view, I think when we first started, we were trying to make sure that we got good amalgamation between the different work streams, but I'm not sure that we achieved that as early as we could have done. And I still think the outputs have been extremely good, but I think we needed to make sure that there was going to be no duplication of effort. The other aspect to it, I think, the publicity campaign has been alluded to. We learnt from the Ipsos Mori poll, and I think many of us were quite horrified about something that we'd assumed loads of people had lots of knowledge about and found that knowledge was very poor. The publicity campaign, I think, has been successful, but I think we could have run it out a little bit further if we'd known some of the things we gradually got to know during the programme earlier, and therefore we could have had a more prolonged publicity campaign. But I think the overall products from the work streams have, I think, been very, very successful.
Thank you. Tom?
Okay. I mean, I think from the intervention work stream, I would say all in all we've been efficient and we've been effective and led by Charlie. And I think sort of an aspect that I think we had regular monthly telephone conferences during the time of the programme. I think on reflection, I think an early face-to-face meeting, I think we would have got to know each other a bit more. Meeting Claire Huckabee for the first time today, face-to-face. We've had lots of telephone calls, but I think sort of that might have opened up other dialogues as well. So.
Okay, thank you. And Fiona?
Yeah, so from the risk work stream point of view, I just felt perhaps like some of the others as well. We probably could have got going a bit sooner, and I thought we produced some great things when we did it. But we had a change of leadership, so I'm very grateful to Andy and Sarah. We've worked really well together, and we've produced some excellent stuff. But perhaps it hasn't stopped us from producing something really good, but perhaps in the earlier stages, as a lay co-chair, there are certain things that I could do in kind of pushing the group on and getting some of our reports and things together. But of course, it's got to be joint, hasn't it? And there's a very, very key medical input to this programme as well.
Thank you. Richard, finally.
Right, well, my colleagues on the couch are all very hypercritical of the things they could have done better. I mean, I will start off by saying I wouldn't have changed a thing. I think we can always think about, how could we have achieved perfection in the programme, and there will always be little bits and pieces we can go. But I think the strength of the programme was that although there were problems, people could solve them, and that was the strength there. I think if the one thing I've learnt big time is the value of communications and communication strategy. I mean, I think that we brought yourself, Peter, and Annie on perhaps later in retrospect. And that branding and that ability to communicate and therefore engage became really the heart of the programme. And that's something I will take forward in any other improvement work that I do, is you've really got to think about that engagement, because it's all very well having the leaders and the vision and that sort of thing, but if you've got nobody following you, nothing's going to happen.
Yeah. Thank you very much. Thank you all. So I know that we've got some questions from the audience. Thank you for those. But Richard, I just wanted to perhaps ask you to tell us how you intend to keep the message alive over the coming months and years, and what are the next steps for you and the next steps for us?
Yeah, so, I mean, what we're seeing today here is the formal close of the programme, but Think Kidneys as a brand, Think Kidneys as a programme of work will continue. It will continue housed within the UK Renal Registry. It will have a programme team. We've secured funding for it, so it's very important to understand that will go forward. And that collaboration with NHS England and NHS Improvement will continue. It will change in some way, but, you know, Joan is still going to be involved, and Mike Durkin will still be, you know, ensuring that we're playing it straight, and you'll hear from him in a moment. But those are very powerful to understand that it's about the stakeholders working with the system to improve the care for the public and for the population that we serve. And I think the challenge, therefore, for us is for everyone in this room to say, I'm a leader here. Okay? It's your job and our job to embed those changes, to start producing the evidence of change, to say that we can do it, and to make it sustainable for the future. So that, you know, I think we've seen the germination now of this idea. Ron's comment, which we'll come back to, that it's in the water. People talk about acute kidney injury now as part of normal business. What we now have to show is that you can sustain improvement, and in doing so, we save individuals from harm, and we also improve the effectiveness of the healthcare system. And I think the NHS and the people in this room and the people out with should be very proud of it. And that should be the incentive to say, chapter 1, we take a breather and we go again and we make it better yet.
Thank you very much. That's great. I have, as you can see, we've been quite organised in the way we've organised these questions, and now it's a bit of a Russian roulette of questions. So thank you very much for those who contributed. I haven't got any names on the cards, but you know who asked them. Richard, I've got a question I think is probably most suitable for you. And the question is, Think Kidneys has helped raise awareness of AKI in children. How can this continue to happen and children remain a key component of the CKD and the KQOL work going forward?
Okay, so I think that's alluding to its role within Think Kidneys and the Kidney Quality Improvement Partnership, which is another item within the Think Kidneys umbrella, which is this idea of, you know, can we improve across the system? So the British Association of Paediatric Nephrologists have been a key stakeholder in this organisation. They have work that's been published around this item. In fact, I'm speaking at their national meeting, which is happening next month, to talk about the care of children with acute kidney injury. And I think, you know, they've also identified their leadership model. They've identified their engagement model, and they are part of it. That's a key group of people that, you know, we need to engage with. And I think that then the wider thing of them being involved in the quality improvement side of things. So, you know, I've been talking about home dialysis, and the paediatric population, again, are a key area within that. So it's, again, how do we engage now that we've got the attention of people and people see the value of improvement? How do you then take it to another area that needs improvement? And I think that's what Think Kidneys has given us.
I think some of the things that we've been hearing about what was good starting points, the foundations, and the things that we learned along the way, freely shared, and is a good starting point for other places.
Well, I think it is. I mean, you know, we've created Lego bricks, and we want people now to build the James May car out of Lego or whatever he did on his program. It's, you know, it's that sort of idea, and to road test and so on. I think the principles are the same. Be you care of the elderly physician, care homes, or paediatric team. You know, the principles are the same. It's how you then adapt it and use it within your setup.
Thank you very much. Fiona, I have one for you, I think. So the question is quite short, but what improvement has AKI programme had for patients, do you think?
Gosh, I would say that I've talked about the resources already that are around there, but actually it's that thing we talked about earlier about being in the water. So I went to a completely different hospital, Watford Hospital, for some voluntary work that I do there. Nothing to do at all with kidneys. They don't have an acute kidney unit there or anything like that. I happened to be talking to an A&E doctor, and I mentioned the words acute kidney injury. Oh yes, I know all about that. I know about the programme. We see it every day. It's a devil of a thing. And so it's being able to hear somebody who has absolutely nothing to do with the kidney community be able to state it from a professional point of view. So I would know that the A&E folk in that particular hospital are watching out for patients. So from that side of things, that's great. But at the same time, we hear regularly through our social media, through the patients that we support, of people who've had acute kidney injury. And like I say, they are now starting to call it, we heard about acute renal failure being the term, but people are now starting to call it that, to say, I had acute kidney injury, I don't know why I had it, but I now know what to look out for. So I think there's a long way to go, because people who don't know anything about their kidneys are going to be suddenly in this situation of thinking, oh my God, I've got this thing and I never knew my kidneys were that important to me. So I think it's the resolute continuation of helping people to understand what they can do to help themselves in the future as well. And we certainly, as a charity, and me personally, it's there all the time. Whenever I see something come up, some information from an HIV charity the other day we were asked to review. They'd missed out AKI. So we were able to go, you need to think about this, here's the Think Kidneys resources. And it's that kind of thing that we can keep on doing with the knowledge that we've got already, that we can share, and I would hope everybody else here will be able to share, because that's where it's going to make the difference for those individuals who are at risk and who have suffered from acute kidney injury.
I think that's one thing that's coming across to me, is that it is multidisciplinary, it's affecting not just a narrow specialism, but a very wide degree of specialisms, and at all levels across the health and care spectrum. So thank you very much for that, Fiona. So Tom, hope you are able to help me with this question, which is, clinical networks and STP plans are very focused on national diabetes priorities. What does the panel recommend to ensure kidneys remain part of the improvement plans and work streams? Or is that unfair of me?
I mean, I think it's ensuring that momentum is built on where we're up to now. And, I think Richard in his first 3 years ago talked about sequencing, and I think we've got to a point, we've got a platform to build on, and it's really important we don't lose momentum of the relevance of acute kidney injury being a real marker of patient safety, and that we can then take that to shift from performance management to learning health systems. And I think sort of in the context of STPs, it's about investment and realising that the shift from trusts and hospital funding shifting out into the community needs sequencing as well, and we need to create realisation of investment out in primary care and across, and build on what we've learned here. Is about the learning across the interface and building on this partnership working that goes on. So I think that's that is critical.
Yeah, I mean, I think I'll just add to that as well, looking to the future. I think that was one of the reasons that we were so keen to take the opportunity to put out the second patient safety alert, which was around sharing the resources. And I think through actually putting that alert out, what we're asking the NHS to do in all the organisations is to really consider, looking to the future, all the organisations that have been produced, to get them to really think about how they can use those, in improving that care. I think that's something that is really positive. So, so obviously looking across the sectors, you're looking from the STP's perspective, but actually being able to do that, I think, actually, again, gives some substance and longevity to the resources that we've been producing.
And just to add as well, I think sort of if we create an evidence base around this, the implementation of AKI embedded into everyday practice and its effectiveness, I think that will give legacy. And I think that's a key. By in the next 7 to 10 years, we need to make sure that there's a strong evidence base around this work that then shapes models of work.
And helps to make it more compelling.
Yeah.
Okay, thank you very much. Thank you. Oh, did you want to?
I was just going to add a really brief comment about the National Clinical Reference Group that we now have for renal, and to say that STPs and acute kidney injury is very much on the programme for that national. The chair of that group is here today, and that's over the next 3 years as well. So there's another way of maintaining that is through that national group too, which is part of NHS England.
All right. Thank you, Fiona, for highlighting that. Mike, I think the next question is for you, and if you don't mind. If you were, and also quite a nice one for you, if you were given £500,000 to work on AKI, what would you do?
I think we've got to look at where that money would be most effectively spent, and there is no doubt at all, and we sort of alluded to it in that previous question, if we can prevent patients coming into hospital, if we can prevent patients ever developing AKI by increasing awareness, increasing the utility of how individuals are cared for in their different environments, we could actually see that this AKI is a sign or a symptom. It should not be regarded as the end disease. We can prevent it. And therefore, prevention using that sort of resource would undoubtedly be where I would be trying to target that money, to really ensure that, carers, professionals know how to prevent the illness, and we know that AKI does occur after patients have been admitted to hospital, so we're not talking about just before hospital, but you can use that resource to really improve knowledge within public, patients and professionals to really ensure that the incidence of AKI is minimised.
Thank you very much. Anyone else want to spend the money?
I'd love it. Publicity.
I would. I've got my director in Manchester in mind, and I would go and double the money and go and get match funding, and I would ensure I'd use some of the money to ensure that we align this work with NIHR, the research arm of the NHS, to go out and get sort of funding to really build the evidence base. I'd use the money then to sort of create capacity building, look at how we look at the medical curriculum and postgraduate training for GP training, invest in improvement science fellows, and I'd take some money and I'd go to Davos and go to the World Economic Forum and say, look, this is a big priority. Let's shift it.
It's going a long way, this money. It's very good. My last question then from the floor is how can CCGs compare AKI cases and rates in their populations? There's a question about benchmarking. I was wondering whether, Richard, you'd like to pick that one up.
So, in fact, actually, you're going to see, if it's not already been published, that the measurement work stream will be producing data by CCG on reported rates of acute kidney injury. Now, that comes out of the Master Patient Index. There have got to be caveats associated with that because we don't have absolute universal coverage of laboratories at the present at the moment. But it is getting to that point that we've been talking about STPs and so on. You know, it's not only about clinicians and a team looking after an individual and saying, how do I do better? It's about how do you get the system to think about what they're doing and how do they set up and resource themselves to improve the health of a population. And that's actually what STP plans, or STPs, because it's got plans already in it, but that's what they should be about, is about how do you best deliver care to a population and how do you understand the relative points along a pathway. And I think, you know, one of the clear narratives that we should develop as a program is the narrative around kidney disease in that setting, because that means different things to different people. We've illustrated that within this program. And that's what STP should be using to understand and improve the health of the population that they're responsible for.
Thank you very much. I think we've got time for one or maybe two questions from the floor. Has anyone got any issues that they would like to ask the panel while they're here? All the answers have been forthcoming. That's very good. Oh, there's one over here. Yes, please. Thank you.
Yeah, I just wondered if the model of the website and the comm strategy and the way the program's been run is being replicated and used elsewhere in other NHS priority programs, because it would strike me as being a great piece of learning.
How would you like to answer that?
Okay, so within the renal arena, I mean, I think it has informed programs around the CKD participation program that we're running in the Kidney Quality Improvement Partnership. But, you know, I have spoken to people, including members of Mike's team, around the antimicrobial resistance and the E. coli sepsis story and, you know, urinary tract infections, you know, to say, is this actually a model that they can take and use and so on from that point of view? I think, you know, that is part of what we need to propagate, is this is a methodology that works. And you go back to the fact it's this amalgam, this synergy between strategy and vision delivered from on high but the fact you've got bottom-up solution driving, all underpinned by solid data to say this is where you're going from that point of view, and allowing programs to grow organically. So I'm a great believer is, never ask for permission, ask for forgiveness later. And that's underpinned a lot of what we've done. Mike better close his ears, quite frankly, at this point. But, that's the issue is that, the NHS as a system needs to learn to trust its staff and its teams and the population, but equally it does need to hold us to account for what we're doing. So, it's that balance that you need to achieve. And I think, that's another big message we can give to other programs.
Thank you very much. Any other? Yes, please. Just at the back there.
Hi, it's fascinating to see it, and it's a great template. I mean, really a question for Joan and Richard is, has the penny dropped with people about the health burden of AKI on unplanned bed usage, the impact on ICUs, etc., which is a hot topic at the moment? So has that resonated with any key audiences at either a local trust level or centrally with NHS England or the DH?
Yeah, I think the resources that we've been developing, the way that we've been implementing those resources, we certainly know anecdotally that those messages are getting out to the areas that we need to be looking at, intensive care and those other areas that you're alluding to.
I think the financial arguments are sort of there. We've had data talking about the cost of acute kidney injury, and I think that sometimes can be very difficult to sort out. But I'd like to move from the pounds, shillings and pence and talking about resources and burden on individuals. And I think that the issue about resources is that message around bed utilisation, both for people with acute kidney injury when they're in, the fact that it extends their stay. If you've got a pneumonia, you stay in longer, your recovery is slower, you're more likely to die as a consequence if you've got AKI. So that's where the Master Patient Index comes in from that point of view. I think the issue about recovery after an episode of acute kidney injury, so a huge rate of readmission after an episode of acute kidney injury, largely down to the nephrologist's fault because we stop all of the drugs that were keeping their heart failure at bay, and we're not clear about how we actually reintegrate that medication strategy into their long-term well-being. So I think there is still work to be done, but that was part of the message that we took 3 years ago to say that there is a burden to the system. I think that we're making good inroads from that, and that's why NHS Improvement and NHS England, I think, want to carry on the dialogue with us because I think they recognise where this fits into the big picture. But Mike will clearly speak about that later.
I think just reflecting on that as well, going back to the national sequin that we implemented as well, the fact that we were so keen to focus on the actual looking at a discharge pathway as well and improving the information at discharge, the fact that we've been empowering through that sequin as well and the work we've been doing in primary care to empower the actual care of the patients to improve, within a primary care environment, certainly again, impacts on, looking at the keeping the patients out of hospital, looks at that bigger sort of long-term discussion as well.
Thank you very much to all of you, and thank you for all your contributions and your questions. I would just like to ask you to thank the panellists in the usual fashion. Thank you.